Health Network. So if you could keep your mics muted until we're at the question and answers section of the presentation, that would be very helpful. And we are going to let people insert questions in chat. We'll be monitoring that, and then we will also be watching to see if people are raising their hands or have any questions. We will have a question section after each presenter, and then we'll have a discussion opportunity at the end of the presentation. So welcome to our 2022 Annual Plan and Budget Community Forum. Hopefully next year we will be in person, but for now we're going to do the best we can with what we have. You should see the agenda for today up on your screen, just to give you an idea of what we will be covering today. So our CEO, Dana Lazenby, will be starting us off, but you will also hear from Anya Eliason and Kimberly Flowers and Diana Bunchu. And I am going to mute myself and turn it over to Dana.
Good afternoon, everybody, and thank you for joining us this afternoon. We're really excited that you could join us. Hopefully, we'll get more people on to hear what we are talking about. We're presenting our annual plan and budget to the community, and we are so open and wanting to hear your feedback and get your questions and concerns and ideas. This is your plan. Honestly, it's we put it together, but it really should represent the wants and the needs of the community. So hopefully all of you know about OCHN by now. I don't think I need to go through the agenda, but I'll just start off with the slide we have here. And OCHN, Oakland Community Health Network, really leads a provider network that assists more than 23,000 people, Oakland County citizens, at more than 300 service sites across the county each year. People who receive our services are public behavioral health services, which is really important for us to say right now. Through OCHN's provider network include those who have an intellectual developmental disability, mental health challenge, substance use disorder, or a combination of those things. So next slide, please. Our mission, hopefully by now you know our mission, and this mission really does mean a lot to you and us. It drives everything that we do, and that is to inspire hope, empower people, and strengthen communities. The vision for OCHN, which is really developed with us and the membership and support of our board, OCHN will be a national leader in the delivery of quality integrated physical health and mental health services and supports to children and adults with intellectual or developmental disabilities, mental illness, and substance use disorder. We respond to our community needs and empower people to achieve the lives that are important to them. And I always say, and I think when I started, we want people to live their best life. And what is that vision for yourself? So as we look at our plan, we want you to think about that as well. Next slide, please. I think I've been here. I just celebrated my 1-year anniversary, and I'm happy, so happy still to be a part of this Oakland Community Health Network family and community. And I hope, if nothing else, I have conveyed to this community that people come first, and we are person focused. So any problem, any issue, any concern, any celebration, accomplishment really should be about persons served and the people who utilize our services or who need to utilize our services. And that's one of the priorities you'll hear about from me, is that really helping to improve access so that people really understand our role in the community is to provide those services and supports. Next slide, please. OCHN's annual plan belongs to the people it serves. Nothing about us without us. And so one of the other things that I really recognize since I joined this community is that many of the committees and work groups and things of that nature always include people who are part of this community who receive services. And I think that's so critical. We cannot develop programs and services and things of that nature without people being a part of that, and people that we serve being a part of that, family members and neighbors and community leaders being a part of that development of those of our annual plan and the services and supports that we provide. Next slide, please. So with that being said, when I first started, I really wanted to observe and see what was going on. And also I continued to work very closely with Michigan Department of Health and Human Services. And so in looking at what our priorities are and looking at the needs of the community, I wanted to make sure that we are aligning with those strategic priorities that are brought forth by our board, but also by the state. Michigan Department of Health and Human Services is who we contract with to be able to do the things that we do. So in saying that, the priorities are, and I'll go through them. The first is to enhance and expand access to non-emergent, urgent, and crisis services. So non-emergent are just those routine, regular appointments and services and supports that people typically need. Urgent means that people need to be seen fairly quickly. They're not in an emergency situation, but they need to be seen within 24 hours. Crisis services are real-time services. When people request crisis services or are in need of crisis services, they need to be seen now, and they need to have some support, some level of support and service and treatment started within 3 hours of being seen and determining what the real need is to alleviate the crisis. We also have a priority to integrate behavioral health care. You know, I've been doing this for 30 years, and I always say the work that I've done has always been integrative. And so when you hear things like behavioral health homes, certified community behavioral health clinics, and complex care coordination, that may not mean a whole lot to people. But when I hear that, it means that I'm not just looking at somebody for what they need in terms of mental health or what they need in terms of their physical health care. I'm really looking at whole life. Where are they living? What kind of social supports and family and friends do they have around them? Do they have transportation? Do people have access to meaningful employment or meaningful work? And then social supports. Is there fun carved out in their life? So when I look at the behavioral health homes, these things are very critical because it does expand access and allows people to come and receive services without some of the standards or some of the definitions put forth through traditional means. So it does allow for people without insurance, without Medicaid, to actually receive services and supports as well. So these are um, um, concepts and programs and models of care that will be rolling out. And it really does expand services and supports for people. But when I talk about integrated behavioral health care, I just want you to know, I believe that the public behavioral health system has been providing this integrated care for some time now. We just haven't clearly defined it and identified it the way these terms and these concepts and models of care have been rolled out. We have a big need to improve the system of care for children and families. I think people have seen the commercials, or not even commercials, I shouldn't say that, the news stories on TV to talk about families and children waiting to receive services. So one of our priorities at OCHN is really to look at how we provide support for children, how they access care, how we are doing prevention work, and how we're looking at our workforce that works for children and the services that are provided to children. We want to make sure that no child, if they ever have to go into a crisis center or into an emergency department, has to wait for services and supports. So you'll be hearing a lot more about how we're working with the improved system of care for children, but we also want to hear any ideas that you may also have. The next thing is provider relations and value-based outcomes. That says a whole lot, but we really want to be in a collaborative relationship with our providers, work very closely with our providers to make sure that the needs of the community are being met and we can measure outcomes for people. It's one thing to check off a box and say you provided a service, but was the service meaningful, and did it help the person and their families achieve the goals that were set forth for them? Last but not at all least, the workforce development. Hopefully you all saw the press release that came out last week where OCHN has decided to provide a $1 hourly pay increase to direct support professionals or service professionals and direct care workers. That definition has been defined by the state, and we're looking at ways to make sure that it's inclusive of the people who provide that essential service and work and not excluding for example, excluding vocational workers as well. So we're looking at ways that we can really help support direct support service professionals and direct care workers, even in the as we look at the pay increase, but also training and education programs that we can provide to support the workforce. And then licensed clinicians. The pandemic has really created a workforce crisis for us. So knowing how to keep, recruit, and retain part of the workforce to do the work means we also have to look at how we support licensed clinicians and are able to recruit workers to work at our service providers in residential settings and all across the system of care that we provide. Next slide, please. So this slide really speaks to what we're really about at Oakland Community Health Network. And if any of you have been to one of our board meetings or one of the committee meetings that we had, the RRAC and the CAC, I'm sorry, this is truly important, and you should feel this when you're engaged with our provider network. That is how important and how essential we all are when we work together. So we're up against some challenges. The legislators are producing two bills that would essentially, one would privatize and one would limit our role in the community. And we really want to advocate for public behavioral health services. The other thing we want to make sure is that we're educating the community and others about who the public behavioral health system is, how to get services, how to work in this community, and also just how to make sure that we're providing and giving back to the community in a way that supports people with needs. And empowering. We want to be an empowering organization. So like as I started with our work, that it allows people to live their best life. So those things are so important that I always talk to people about being ambassadors. If anybody's familiar with the Disney theme or been to Disney World or even seen a Disney movie, one of the ways that they talk about Disney is every single person who works for Disney is a greeter and an ambassador of what they believe to be fun. So I think in this instance, we are all ambassadors for the public system and all ambassadors against stigma so that people can access the services and supports they so truly need. So with that, I will stop and take any questions. Do we have anything yet, Christine?
I do not see anything in the chat, and I don't see any hands raised. You did an excellent job.
Thank you. So I think we're going next to Anya.
Anya, you're muted. Is your microphone giving you a hard time? Maybe we can move on to Kimberly and maybe Diana can help you. Well, there you go.
All right. Of course, it's giving me a hard time. I didn't think to check that before I was up. Okay, so again, just verifying you can hear me okay.
Yeah,
so for
we can.
thanks, Christine. So for budget and finance, we're going to talk a little bit about the budget development process and how that process works. That starts back in June of this year. We start to take a look at where the current fiscal year is looking to project to end at. So does it look like our spending is consistent with what we budgeted? What do we think that's going to look like for the end of the year based on the current revenue we're getting? Will there be any excess funds that we can contribute to our Medicaid savings? And really, how is the network spending? Have things gone up? Have things gone down? Definitely with the pandemic, we have seen a reduction in just volume alone. So that has definitely impacted our finances. But we take a look at where we're at currently in this fiscal year. If we have rates from the department for the next fiscal year, we will start to project what that looks like, including what we think the eligibility trend is going to be for the next fiscal year. So as we hopefully are coming out of a pandemic, we should expect eligibility to go down a bit. So we've built some of that into our budget for next fiscal year, meaning that as eligibility for Medicaid goes down, so does our revenue. So when we do projections, we try to make sure we're including some of those factors that will play into the amount of revenue we get. But at this point, we're just making estimates, and as we go throughout the fiscal year, we will update what those estimates look like based on our actual experience. Once we did our budget estimates, we look at, based on spending and the projected spending for the next fiscal year, what we think we're going to have to work with for fiscal year 22. And in doing that, we were able to, as Dana mentioned, look at things like a direct care wage increase. As we know, we've had a significant direct care professional shortage in Michigan for the last several years, and the pandemic definitely exacerbated that issue. So it is our intent to start to roll that out for October 1, pending board approval. And then we'll be reviewing our revenue throughout the fiscal year to determine if there's any excess revenue we can again utilize to do that. And that will be regardless of whether the state approves the extension or making permanent the 225 they are currently funding. If they do fund that, we'll add that in a later amendment, but we will be passing that through whatever they fund. In addition to being able to do that, we plan to continue to stabilize our network through the pandemic. So for what that means for providers is many of them are still on cost reimbursed contracts, which means Medicaid allowable costs that are reasonable and appropriate are covered. And we've been on that with the majority of the providers through the pandemic. We did have in fiscal year 21, the adult providers were able to go back to their standard service models due to being able to have the volume to manage within those models. Several of the networks are not there yet. Kids services is not there yet. Vocational services is not ready yet. So we've committed to looking at that each quarter and determining with the provider input if we are able to move back to service models. That definitely is the goal. We just don't want to do it in a manner that puts the providers in jeopardy or any of the individuals served in jeopardy. One of the other things we're doing in fiscal year 22 will be to roll out a pilot for direct care professionals. We started talking about that last fiscal year and have just selected the providers that will be participating. And what that's going to be is a pilot to determine if we pay higher wages in direct care professional settings, does that make an impact on the outcomes for individuals? What does that mean for turnover? What does it mean for overall costs? To really see if that does make a difference, and if so, what difference does it make? That we're pretty excited about, just because hopefully we can get some good data to compare to our standard direct service rates and to determine if that's a viable plan going forward. One of the other things we did hear from providers and in the annual plan feedback was that, as Dana mentioned, the master's level clinical staff, the market has become very, very challenging just with the continuation of telemed. They're seeing it tougher and tougher to recruit and retain master's level clinicians just because there are so many options for them right now. So we are planning to make an adjustment, again, pending board approval, to what is funded for the master's level clinical staff in both the MI adult or adults with mental illness network and kids with serious emotional disturbances network. And I think that's it right now that we heard that feedback from. So the other one of our key priorities this fiscal year will be to work on the Children's Crisis Unit, which Dana mentioned, related to crisis services and children's services. So we have budgeted to implement that. And finally, to contribute to our Medicaid Internal Services Fund, or sometimes I'll refer to it as Medicaid Savings. In fiscal year 18 and 19, we were lucky enough to have the reserves to cover the deficits of those years, totaling $25 million, and did not reduce services or reduce rates to any providers during that time period. And that really was because we had the money in what is the equivalent of our savings account to be able to cover those losses. So it is our intent to start to recontribute to that. We've come a long way since then. In fiscal year 20, we're at about break even. So we've swung the pendulum quite a bit. And in fiscal year 21, we hope to be able to start putting back in, and again in fiscal year 22. The long-term goal being having a fully funded ISF so that if and when we have another shortfall, we do have the funds to cover it and have it not impact individuals or providers. With that, I think there might be a question slide. After this, I can take any questions if anyone has them. Christine, are you calling on hands or am I?
I see Judy has her hand raised, so you can unmute yourself, Judy.
I know the muted Judy's better. I'm just still curious about the pilot, Anya. How did you determine who would be the participants, and if in fact the outcomes are determined, will the rates return to their previous quarter, or are we going to go ahead and look at extending the increase?
So there was a review committee. So we did kind of not a full RFP, but more of a request for interest to participate. And there was specific criteria related to providers that could participate, the variety of different situations we wanted to make sure we were covering. And so there was a committee that reviewed that information and then selected the 10 providers that seemed to fit that request the best, and we notified them that they would be participating just to make sure we got a good cross section of different situations, different individuals, and different providers. The pilot is intended to be a minimum of 6 months up to a year, and quite honestly, we haven't gotten that far to decide really what happens after. I think it will a lot depend on what the data says. Does the data say this really makes an impact? Does the data say that it's impacting outcomes and the expense, either if it's up or down, is it impacting service delivery enough to be able to say that it would be worth the investment to do that long term? If the legislature approves the 225 and with the dollar we are providing, we're going to be pretty close to $15 an hour at our funding. So depending on the number we end up with, we may not be that far off from whatever the pilot ends up to be, because that hasn't been decided yet. So a lot of it just depends on how some of the things play out over the next 6 months to a year before we can really tell what our long-term plan will be for that pilot.
Okay, so does the overall picture include currently employed or recruited direct support professionals?
So I believe it is currently employed direct support professionals, but I actually will need to circle back on that one. I believe that is the intent, because I think the goal really would be to have people that are currently employed, already trained, familiar with the service delivery, and hopefully this would help retain them. I don't know that it's intended to be, okay, bring on a bunch of new people, but I would have to circle back just to verify that for you.
Okay, great. Thank you.
Yep.
I do not see any other hands raised or questions in the chat, so I think we can move on to Kimberly. Thanks, Anya.
Yep.
Good afternoon, everybody. I am Kimberly Flowers, the Chief Clinical Officer here, and very happy to be here at Oakland. And I've been here for about 3 months, so this is my opportunity to speak to you regarding some of the services and wellness programs that we have right now. I'm believing you'll probably see by now there is a theme. So our CEO kind of lays the groundwork for everything, and then we come together with our programs and support the initiatives and the needs of the community. So the first slide here speaks to healthcare and wellness. And it talks about health homes. So the health homes provide comprehensive care management and coordination. The first health home I'd like to talk a little bit about is our behavioral health home. We have this program and is a health service delivery model, which is focused on combining the primary care, mental health services, as well as social services and supports for adults and children. So for our SMI populations and our SED, those with those diagnoses. We have these programs that are available right now through many of our providers. And the whole intent of this and this whole section is regarding integrated care. We spoke about integrated care and that the fact that behavioral health and public behavioral health has been working toward integrated care for a very long time. So now there are programs now that speak to it directly and that are focused on some folks with Medicaid already who have, again, SMI or SED diagnoses. And then also we have programs, and I'm going right into CCBHC as well, for programs that also work with improving health outcomes and treatment access with our CCBHC, the Certified Community Behavioral Health Clinics. Both of these programs are organized and have a goal to ensure that there is transition or care management or care coordination between all of the areas of your needs and then also the areas of physical and or medical health and as well as SUD services. So you'll find again the behavioral health home is for folks who really have Medicaid already, but then you have our certified behavioral health clinics who, regardless of your ability to pay, those services are available to you and hopefully are designed to provide a comprehensive range of mental health services and substance abuse disorder services, particularly to those who are vulnerable. And the CCBHC as well has an area stipulation that wants to focus on those who are veterans and those who are serving right now as well in services, in our military services. So all of these services are coming together in hopes that there is integration through all levels of need. So regardless of your ability to pay, regardless of where you find yourself in the community, working through the judicial systems, the school systems, going into physical health and all areas so that we work together to ensure healthcare and wellness for everyone who touched the system in any way. So if you need to know more about those programs, please do contact our access program or even your providers if you're already in services. Opioid health homes is an area where we plan to look at in 2020, fiscal year 2022, and begin to set up our processes so that we can also develop opioid health home programs to do much of the same work, but for those with SUD diagnosis, specifically opioid and needs for those persons who are working and struggling with the SUD needs in those areas. Next, I look at the emergency department and hospital visits. So right now, I think Dana mentioned that we have understood already the need for some support in areas where we have particularly children and adults spending larger or longer lengths of stay and longer lengths of time in the hospital EDs. So we're working with the hospitals, and our intent is to do that going further, to work with the hospitals in the community to create a collaborative effort to understand that there are no barriers and to understand where our beds are. And if there are struggles finding inpatient beds, what we can do about that and how we can get around that. So we're paying closer attention to those areas. And again, working with hospitals and making partnerships with those hospitals in order to be able to have an outcome that is better than that we don't allow people to stay on the EDs for very long. Next slide, please. Supports and services. Right now, going along with the extended ED stays, we are working specifically for our children and family and working to establish a crisis stabilization unit. The crisis stabilization unit is going to be very similar to OASIS, but it is going to be for children specifically. going to do the screening and coordination of care for those children who are in crisis. We're hoping that having beds and a unit available in the community will decrease the length specifically for our children who stay in the EDs. And we hope that this will, we know that this will allow for a better outcome. This will provide additional coordination of care with our providers, and again, create better working relationships with the hospitals in the community so that they understand who they can call, what resources we have, and how to secure service for children who are in crisis. In addition to that, what is not necessarily listed here is our hospital liaison. We have created a new position for our hospital liaison to be able to also work and partner with the hospitals and with our crisis stabilization units and with our providers to ensure that children are wrapped around after crisis happens, or once crisis occurs, we're in crisis, we get the core provider agencies involved. We talk with the hospital EDs. We talk with our crisis stabilization unit, and then we understand what the bed situation looks like, and even also what care will look like beyond the hospital stay, should a hospital stay be required. In the event that it's not, we've also begun looking at all of the services that we have, our full children's array of services, to understand that if there is crisis, that everyone knows our new center that we're our crisis stabilization unit, and also our intensive crisis stabilization, our mobile crisis units are activated in the community as they need to serve, possibly in the community or in support of people who have just recently gone home and need some support while we wait for an appointment with a follow-up when they didn't necessarily need hospitalization. So we're working really hard in that vein to ensure that we wrap services around our children, both from prevention through to crisis and beyond. So just know to just that we're looking at those areas right now, and we count that as a very important area of our work in the future, and especially 2022. Diversity, equity, and inclusion. Diversity, equity, and inclusion uses best practices to implement recommendations from OCHN's organizational assessment and committees on diversity, equity, and inclusion to ensure OCHN and its provider network is accountable to be a safe, equitable, inclusive, and supportive environment for everyone. And I know that's a lot of words, and when I think about supports and services with respect to diversity, equity, and inclusion, it makes me think that we want to be sure that all of our providers, everyone, and all of the folks who work in administration at OCHN keep these elements in mind when we're reviewing our programming, when we're creating new assessments, when we're creating new sites and areas for care. And we want these areas to be at the forefront and included in those plans and processes. So that was an important piece to put here so that everyone understands that we do understand that equity, inclusion, and diversity are very important elements in planning any kind of programming for persons in the community and persons everywhere. Justice and initiatives. Improve the well-being and recovery for individuals at risk of incarceration. OCHN right now actively engages with community partners in law enforcement, correction, courts, probation, parole, juvenile justice to divert people with behavioral health care treatment needs into appropriate services and opportunities to divert from incarceration for further involvement in the justice system are expanding rapidly. So what we're trying to do is we have many initiatives that work with our justice systems to support identifying behavioral health diagnoses when folks persons are having to interface with law enforcement. We have crisis intervention training programs, jail services. We're active within the courts, probation and parole, and juvenile justice as well. Because what we want to do is train and alert and have everyone who touches persons to be aware that there may be working with an individual who has a behavioral health need, and to be able to understand where that person would need to have services in lieu of law enforcement or corrections and things like that. So we're very much at the table with our justice initiatives to be sure that we make people aware of the services that we provide, and even down to those who are directly, I call boots to the ground, and who understand and see people every day who might be in need of services. We want those doors to be open and everyone to understand how to access care. Next slide, please. Finally, social supports and services. Social determinants of health address factors that influence the health of individuals. So our social determinants of health are conditions in the environment where people are born, where they live, learn, work, play, worship, and they affect a wide range of people with their health, functioning ability in the community, and quality of life outcomes and risks. We want to, and we do, and we review and look for areas for housing, transportation, neighborhoods. We look at their education opportunities, job opportunities that people might have, the income that's available to people, the nutrition, the ability to access proper nutrition, and any other activities, language and literacy, when we are reviewing the types of services that we want to provide. All these things are very detrimental and very crucial in planning care and planning programs that support persons in the community. So we want you to know that we every day and every time we come together and to the table and collaborate, these areas are included in our thoughts when we're creating plans and assisting in the community partners and addressing all of these areas of social determinants of health and program planning. Substance use prevention and treatment. We partner with providers and community stakeholders to lead prevention initiatives, connect individuals to treatment, and promote healthy recovery lifestyles. And finally, in our suicide prevention area, we continue to collaborate with local and state work groups to implement the zero suicide practices. We sit at the local areas and collaborations to discuss how we can work together to be sure that everyone is practicing zero suicide and pathways to such. And now we also have someone who's been assigned to our state work group, so we're very proud of that, to be able to hear what the state is speaking of, to bring that down to our local areas, to ensure that we are also moving toward the zero suicide practices and pathways to such. I think with that, I have said a mouthful. Thank you for being patient with me. And if you have any questions, I am certainly open to answering them.
Thank you, Kimberly. That was very thorough and informative. I do not see any hands raised, and I do not see anything in the chat. And it looks like Diana is ready.
Thank you very much.
Hello, good afternoon, everyone. I am Diana Bunchu, and I am the Chief Information Officer for OCHN. The first thing that we're going to be working on this year is technologies to promote independence. This actually isn't a new initiative. We had picked this up a couple of years ago before COVID hit. And what we're looking at here is what can we do to help people to be able to have the independence they want, to be able to stay in their home. And there's lots of choices that have come out, from things from smart homes to fancy pill dispensers, telemedicine, different things. One of the things, though, is that we are talking about independence here, but really for this, we will continue to look for any technology that will continue to support and help people when it comes to the mental health, recovery. What we are seeing is a lot of technology development, applications, and solutions in really trying to help, as we've all talked about today, the needs for people with mental health. The second one is health information and data exchange. This is something that we've also been working for several years on. I'm really excited about this particular project, and it is e-consent. E-consent is what is going to allow us to finally be able to share data for those people who are receiving substance use disorder services. Due to federal regulations, that is something that we haven't been able to do. We are working with MDHHS in Mayan, who is the main hub of a health information exchange in the state of Michigan. So what people receiving services will be able to do is to sign a consent saying that we can release that information, and then whether it's a doctor or a healthcare provider would be able to access the information. And, you know, we've been talking a lot about integrated care and being able to coordinate care as well. And this is one of the things that will really, really help. I presented on HIE, or Health Information Exchange, a couple years ago at Your Voice, Your Value conference. And this was something that we talked about that we couldn't do. So now to be able to see us moving forward is really exciting. The last one is public transparency and outcomes data. For those of you who have been to our website recently, about a year ago, we added dashboards and information. So you can actually go to our website and look to see how many people we're serving, how many people are actively open, and different types of information are now available. So we wanted to continue to grow that data transparency for the public. And the next one is really exciting. This will be a big partnership with IT and Christine's group, as well as other stakeholders. And that is, we're going to be designing and implementing a new website. Our website has been in place now for a few years, and usually every 3 years or so, you need to go through and do a refresh. And what's exciting is we're going to be able to rebuild this from the ground up and be able to figure out how we can make it in a way that is easy to access information and that people can find what you're looking for, whether it's a provider, someone receiving services, or even a family member or friend who's looking for additional information. Next slide, Christine. And with that, I'm happy to answer any questions.
I do not see any hands. I do want to remind people that are on the phone, if you hit *6, we will be able to hear you. And I'm not sure if I mentioned that before.
Great, thanks, Christine.
We did want to just give people some time, now that we've gone through the entire presentation, if there were any questions or if there was anything of interest you want to comment about that you heard today or saw in the presentation, now would be the opportunity. Or if there was something you didn't hear, we really want to make sure that the plan is capturing and reflects the views of the people we serve and of our community. So this is a great opportunity to offer suggestions or input to our leadership about things you might want to see added to the plan. Not seeing anything, so I am going to turn it back over to Dana to just give our closing remarks.
Thank you, Christine, and thank you, Diana, Anya, and Kimberly, for such great comprehensive presentations. I do want to stress the importance of hearing from you all. We are getting some initial feedback from our annual plan. And one thing in particular that's really important to us is that we're hearing about peer supports and peer services and talking about how we are more inclusive and making sure we're utilizing our peers to the fullest potential, because we know how valuable they are to our community. So if you have ideas or additional questions or requests related to that, please do not hesitate. We always talk about an open door, but we truly believe in the open door, and we truly want to partner with this community as well as with our providers on ways that really enhance the service delivery and outcomes for people. Real outcomes, not just checking off boxes. We really want to see meaningful life changes for people. I did see something, I believe, in the chat. It was a question. I just came up.
Yeah, it does. Teresa Scott typed in the chat and just said, can you explain a little more to me about the Privatization Act they are trying to pass?
Sure. Teresa, there are two legislative bills that are out there. Well, there are more than one, but I'll combine them into two because they're being represented by um, Senator Shirkey and then House Representative Mary Wyford. So the first one for Shirkey is really a privatization. And so what it does is that it eliminates us as a prepaid inpatient health plan and gives it to the Medicaid health plans. So what the way I think about it is it's a renewal of Section 298 that was out a few years ago. And in response to 298, what happened was is that the advocates and the families and persons served really spoke out because the plans never really included or were designed around persons served. This was something that was really what some call a way just to integrate funds. They talked about integrated care, but really it was a way to integrate the funding and take the funding out of the public system and give it to the private or Medicaid health plans. The second bill is a little different in that it's talking about eliminating the PHPs, which is we are one of 10, and really creating what is called a authorized service organization or ASO. So really it's a step away from privatization, but it's no guarantee that would not be a private entity that would operate as an ASO. And what this ASO would do essentially is to manage not even manage care, but really manage all of the administrative functions that are currently managed by the 10 prepaid inpatient health plans or PHPs or community mental health system. So you will still see portions of community mental health with this proposal, but it's still not very clear on what that would finally look like at the end. One of the, I guess, advantages of the Wyford plan is that she is actually talking to people and talking to groups about the vision. So I think that's important. And I think that people should know when those opportunities are to listen and to hear her plan and to ask questions. And so with your question, when you asked to talk a little bit about what Privatization Act is or what they're trying to do, I think it's important that we let you know we have a listening session with Wyford coming up on Monday. And so we'll be sharing that information. I'm not quite sure if Christine and her team are ready or if they could even put something up for us now with flyer or the.
Yeah, Dana, we actually just sent the flyers complete. We sent it to Representative Whiteford's office for their approval first, but we should hear something hopefully by the end of the day. And we do have everyone's email address on this list, so we'll make sure to get it to them.
So Teresa, if you just bear with us, and those of you on the phone, as soon as we get approval and get confirmation for Monday's listening session, we really encourage everyone who can participate to do that. Because it's important that it's one thing for us who are here working on this side of the house, but we really want people served to really understand what's being proposed and have an opportunity to answer questions and to really get a real idea of what people are talking about. It can be very confusing. I know even for those of us who look at it every day, my hope is that some of this stuff, we can address some of the concerns like we just did in our annual plan and budget review so that we can really address those things that we know are not perfect with our system, but we're really striving to improve and make better and not completely overhaul the system. So I really want to hear what she has to say, and hopefully we will get an opportunity to work with the legislators on what we meaning all of us, including persons served, especially including persons served and their families, have some strong input and say about what the system looks like in any redesign plans. So I'm sorry I can't give you a better answer than that, but that's really, our understanding of it as of now. Absolutely. We'll make sure in the chat. I see you again, Teresa. You say I would like to be involved in any community meetings about this. So please send me any invites to participate in any meetings. Thank you. We definitely will. Thank you so much. Does anybody else have questions about that? I hesitate to bring it up and talk about it in this forum because there's still a lot of unanswered questions, and we're still trying to get a clear idea of what the vision is for any system redesign. But we definitely want to make sure that anytime we're at the table talking about it, that persons served and families in the community are involved as well. Anybody else? So Christine, can you just give us a high level view of our timelines and what we're looking at in terms of getting feedback? And I know some people aren't on this presentation, and then some people don't like to speak out or to be in chat or any of those things, but we do encourage you. There are several ways that you can give us feedback.
Sure, I can do that. We've been collecting feedback or gathering it for a few months. There is a survey on our website. I'm going to type in our website address into the chat. You can click on that. You can also contact our customer services department. They will help you complete the survey if you need assistance. You're welcome to contact me by email. I'll put my email in the chat as well. And then we are, Suzanne beat me to it. She's typing faster than I am, and that's okay. But you can email me any questions, and I will make sure that your comments are noted and shared with our leadership. We have always made it a practice to take input and feedback right up to the time it's presented to our board. I know our leadership is meeting with our board to go over the plan with them this week and to get their thoughts and to share what we have been hearing from the community. I do want to note that based on all the things I have seen in terms of the strategic priorities that Dana outlined and Kimberly and Anya and Diana covered today, I think they did a really nice job of capturing people's thoughts and feelings and reflecting it in the plan. But again, if there's something we miss, you can contact us any one of those ways, and we'll be sure to reach back out to you. But up until it's approved by our board, which is in September, we welcome feedback.
We also invite you to attend any of our board meetings. Our board meetings are open to the public. They are virtual, or you can also participate in person. We have some capacity to have people come to our office in Troy to be a part of those meetings. It's really important to hear those updates, and I would love to be able to meet people that I have been meeting with virtually. Now it's time to meet people face to face. So we invite you to those meetings as well.
We do have another question. So Lynn, I hope I don't mess up your name. I think it's Tamer. In terms of user involvement for the redesign, we did have an individual who received services and has a background in web design participate in the RFP process. And then once the redesign is completed, we will be sharing it with various work group members, with our board and some of our community partners for their input in terms of friendliness and accessibility. But I will keep you on our list as someone to share that with. Not sure I'm seeing anything else in the chat, Dana, or any hands raised.
No. Well, I want to thank everybody for taking the time this afternoon to really come and listen to the annual plan. Again, we really appreciate your support and your feedback, and we are always open to opportunities to improve and also ideas. We like to hear ideas from the community. Again, it's important to have that as a part of the design and development improvement to access integrated care, our relationships with our providers, particularly looking at integrated services for children, and then also a very important workforce that none of us could do any of these things without direct support professionals and our master level and any clinical teams that are supported by administration. And I think it takes all of us to really make this all work. So I really want to thank you all for taking the time this afternoon to spend with us and hear about our plan. And as Christine and Suzanne talked about, this is being recorded. So hopefully you'll get an opportunity if there's somebody who wanted to participate and could not, share it with them and let them know that it is available on our website. And with that, I don't know if anybody has any other closing remarks. I will thank you all and have a great evening.
Thank you, Dana. Thank you, everyone, for joining us today. We greatly appreciate your participation.
Bye-bye.